Hi everyone, welcome to today's webinar, AOD 101 Part 2. My name's James Petty. I'm from the Victorian Alcohol and Drug Association, and I'm a project officer there. So I'd like to begin today by acknowledging the traditional owners of the land on which we are meeting today. I'm in Brunswick, so I'd like to acknowledge the Wurundjeri Willem as the traditional owners of this land and the waters of the Mary Mary, and pay my respects to their elders past, present and emerging. And I'd like to extend that respect to the traditional owners of the varied lands from which other people are attending, as well as to any Indigenous people who are joining us today. This is stolen land and sovereignty was never ceded. So today's webinar, AOD 101 Part 2, follows on from a very successful Part 1 last week. If you weren't able to attend last week, please get in touch with someone at VADA and we can send you a link to the recording, and I'll post an email where you can get in touch with us in the chat function. This webinar is presented as part of the Therapeutic initiative, which is a collaboration between the Victorian Alcohol and Drug Association, the Victorian Healthcare Association and the Centre for Excellence in Child and Family Welfare. Therapeutic is also supported by the Victorian Government. If you haven't already, sign up to the newsletters of either VADA, VHA or the Centre and you can stay up to date with Therapeutic and what we're doing. So just a couple of housekeeping items. Today's session is being recorded and the slides will be available afterwards. If you have a question, please ask it using the Q&A function at the bottom of your screen. You can also upvote other people's questions. I will monitor the comment section, but it won't be not closely. And we also have a short poll that we'd like attendees to fill out after the webinar. So we'll make that available at about the 1 hour mark. So if anyone's leaving early, they can fill it. And yeah, we'd really appreciate it if you could fill out the poll before you leave. Okay, I'm going to hand off to my colleague Jane, who's going to introduce the speakers. Thanks.
Thanks, James. Good afternoon, everyone. Today we have two speakers for you. We have Olivia Nichols from Odyssey House, and she's going to talk through quite a bit about treatment itself. I know last week we did sort of the overview of the whole sector. This week Olivia is going to be drilling down to what's involved in treatment, and she's also going to give you some background about various substances and their effects on the body. Following Olivia, we are going to have Kit speak to us. Kit is a consumer consultant at Uniting Care Regen, and they will give us some insight into what it's like being a consumer in the AOD system, and they will tell you a bit about their journey right from the start of treatment through to now. So yes, I'd like to welcome both of you. Well, what we might do is swap it round. So we might actually hear from Kit first. And yeah, then we can try and sort out what's going on with your mic in the meantime. Okay.
Hopefully my audio is working okay.
Your audio is working very well. Thank you, Kit.
Thanks, Jane. I'll start by acknowledging that I'm on the land of the Yaluk William clan of the Boonwurrung, and also acknowledging that sovereignty was never ceded. So where to start? I'm going to be speaking mostly about what my experience was like. It's a little bit about the background of me before treatment, but mostly about my experience in accessing treatment. I started using meth when I was about 21, and for a long time it was something I used that wasn't problematic for me and was quite fun. After the death of my mother and a few other things, about the age of 25, 26, I started using meth a lot more. I was using meth daily and became dependent on it. I would have recognized that it was problematic, but not willing to do anything about it. Later on, about the age of 28, I by now become heavily dependent on meth, was using daily and was in quite a problematic state. At that age, I also was homeless, and I entered a relationship that was an unsafe relationship. The person I was with used violence. he also used differently to I did. I previously had smoked meth, he injected. So about the age of 28, I shifted and became an injecting meth user, which ratcheted up everything really. So I was using daily and heavily dependent. In about, that relationship ended, and then in about mid-2018, I moved into Flagstaff Crisis Accommodation, which is a crisis accommodation service in the city. That was the first point that I engaged with AOD treatment, really, an AOD outreach service that is based in Flagstaff. I began working with a care and recovery coordinator there, Eliana, who was amazing, sympathetic, empathetic, but also curious about my life, not judgmental, but honest, reminding me gently when I disengaged to re-engage, and helping me to feel safe and prepared to take more steps, but not pushing me to take more. I wasn't really ready to make change at this stage. I was just contemplating the possibility of making change. I knew then, and I could explain, that I had lost nearly all of my capacity to regulate my emotions. My thinking was quite disordered and scattered. I was still in a very high alert, highly reactive mode. I was still regularly using and still often in a kind of, panic mode. Very high level of activity, very, everything was sort of turbocharged. I engaged with her and through her with some other services. The first thing we started to look at was vein care. I'd been using a lot and my veins were in not very good condition. And I ended up with associated injuries from using regularly. At this point, harm reduction was really what I needed, and I wasn't prepared to stop using, but I did want to reduce the harm. I could share that problem and get help. People were not suggesting that I should stop using, they were suggesting that I could use in other ways and suggesting services that could help me to use in a safer way. Flagstaff had an on-site NSP, which was fantastic. Being supported to use safely changes everything for me. It recognised that while I did want to use, I didn't want to hurt myself, and helped me to not hurt myself. One of the first big things that Eliana did was take me to the supervised injecting room. She introduced me to the service and supported me in engaging with that support and education around vein care. It was fantastic, practical, supportive harm reduction. I wouldn't have travelled there on my own. I would have been too scared. But being taken there and then being taken home afterwards was fantastic. The next thing she did was refer me to and help me engage with non-residential withdrawal nursing from Regen, which is an outreach service at Flagstaff. He provided advice and assistance on a step-down plan. He did the comprehensive intake and assessment with me, helped me to find a good local GP who specialised in AOD stuff at CoHealth, and also took me to my first appointment there and took me home, practically and literally introducing me to other people so that I wasn't doing any of those things on my own. It makes them a whole lot less scary. Through her, I was able to get some medication to help me with supporting with my withdrawal and my detox, and to help me start to do that step-down plan. I remember his initial advice was to not cut down by more than 25% a week. And that was really practical, helpful things, saying don't take on too much, and that making these big changes would take time. The next thing that happened was referrals were made, and we started to look at getting me some longer term, more intensive support for residential rehabilitation. Referrals were made to the two therapeutic communities, both Windana and Odyssey. And I went to an info session at Quinn House, which is another residential program which is in the city, which primarily treats clients who are homeless men. And Flagstaff also is a service that exists only for men. I don't identify as male, but services are often gendered, and these were the services I could take. So for that period of time, I was in that male environment and read as male, even though that isn't my gender. I went for a psych assessment because Odyssey had requested one after that referral. That took a little while to get. About a month waiting for that appointment. Eliana had organised that referral for me, as well as finding a good site to do that. It was that turning point. I was also taken and went and did that. The report came through later, and it was helpful in some ways, but in other ways it limited me. It identified that because of my other mental health conditions, I would benefit from a dual diagnosis treatment service. We know from Marie Tennyson, work in research in 2015, that mental health and substance use disorder coexist. Around 90% of clients in AOD treatment services have mental health issues, and 71% of clients in mental health services have substance use issues. PTSD is almost universal, and I know for me that I have still got chronic and complex PTSD. I agreed with their opinion and their reflection that dual diagnosis support would be helpful and be best, but that limited my options. There are less of those services. Around that time, a new residential rehabilitation program was opening, and I was referred to that, which is Westside Lodge in Sunshine. I was on that waiting list, and that waiting list for quite a long time. And in that period of waiting, I was sort of in a state of flux, both wanting to make some changes, but not able to get the intensive support to make the changes I needed to make yet. It was sort of a bit of a no man's land for a little while. I went for an interview at Quinn House to see about getting in, but they turned me down. They felt that I was not quite enthusiastic enough, I think, because I had expressed some reticence about how enthusiastic I was about making change. I was very scared of the idea of changing at that stage. I was also a bit reticent about going to a place that was for men. By this stage, sort of late spring, summer 2018, I was feeling more stable. I was feeling less like I was in crisis. I'd had secured housing for quite a chunk of time, but I was still using very regularly, most days, at most, 4 days off. And I was still really scared about the idea of permanently stopping using. The only friends and connections and social supports I had were people who used. I had some friends and made some connections at Flagstaff, but it is also a place where nearly everyone was using. And the idea of giving up, and therefore giving up all of my connections to the world and my friends, everyone I knew, was really scary. I had been referred to one-on-one AOD counselling, and I went to an appointment, a single appointment at this stage at Regen. I wasn't able really to engage with counselling then. I still had a bit too much despair and a bit too, my head didn't have the ability to really sit in a room for that long or reflect. I remember saying quite loudly and firmly in that appointment with the counsellor that everything was fucked and that it was too late. Everything was just too late. I couldn't settle physically and I couldn't settle mentally. I was still really dealing with the ripple effects, the after effects of previous trauma and trauma associated with my previous relationship and that kind of psychological abuse and torturing. And my former partner was still in some contact with me. It was a very complex time. In early 2019, a place finally came up at Westside Lodge. Before I went, I was absolutely terrified about going there. I was really worried that I wouldn't be able to cope. I was really worried that I'd be lonely. And that if I left Westside, where I would end up, I didn't know what would happen. I was really hesitant about going. I had a conversation with two workers at Flagstaff about whether or not I would take up on that offer. I was crying in that conversation. I was very scared. But at the end of that conversation, I decided that I'd take them up on that offer, and I went. Part of that is also that I was very scared and sad about leaving Flagstaff. It's can be a very aggressive place, and it can be a scary place. But I'd been living there for a long time. I made friends and felt safe there. I felt supported there, and I felt like my humanity had been recognised there. Their approach, which was quite trauma-informed, gave me that stability and allowed me to be a bit insane when I was a bit insane, and allowed me to slow down and recognise that slowing down and feeling safe would take a long time for me. So I was at Westside for 3 months. It's quite a small rehabilitation program, 20 beds, about 17 people were there when I was there at most, with a reasonably large multidisciplinary team, psychiatric treatment, psychological treatment, AOD treatment, social work support. Yeah, it was there that I really learned that I had capacity to make radical changes. It was the first time that I realised that I could once again function without meth. And then once I wasn't using, I could start to at least face some of the trauma that I was carrying. Once I wasn't using, I was able to slowly begin the task of relearning how to regulate my emotions. I could start practicing making some social connections with other people without substances. My mind and my body were still in hyperdrive when I was there. I remembered having so much energy that I cleaned the skirting boards. I couldn't sit still for particularly long. I couldn't focus. It takes a long time to slow down, but at the end of those 3 months, I had started to be able to sit again. I could start reading again. I was reading short stories. At the end of that 3 months, the thing I also noticed was that other people who were just arriving were also, as I had when I'd arrived, in a hyper state. They were in hyperdrive. I could see that often that experience of that much energy and that much constant discomfort of just existing in your body is really overwhelming. It can feel like agony at times, a sort of constant restless nervousness, listlessness and a restlessness that's sort of overwhelming. After I left Westside Lodge, I moved back to Flagstaff for about a month because I didn't have any other stable housing. And then I moved into the place that I'm living in now, which is transitional housing. I've lived here for a bit over a year on my own. The next thing I did was a non-residential rehabilitation program at Regen. So that's a program where you go every day, but then you come home at night. It's a 6 weeks program using mostly CBT, but also some other stuff, some mood management stuff, some motivation enhancement. For me, it was really valuable in transitioning from a highly supported environment to one where I was on my own. It gave me the chance to step down from the amount of support, to start to get me some training wheels to become more self-sufficient, to learn how to engage when I needed support and how to be on my own when I didn't need support. In that program, I used once and I had a couple of days off, and then I re-engaged, and I was supported to re-engage. A lapse I wasn't penalised for a lapse, but I was supported, and particularly supported to re-engage. I learned that that was the practical learning, that the thing to do was to come back, to continue to re-engage, and that was always going to be easier, and that no one else would be telling me off. Maybe I would be, but no one else would be. I engaged with AOD counselling at the end of that program, which was in about last year, September of last year. I did a full treatment episode of AOD counselling that I found really helpful. I also started doing another couple of AOD support programs, Smart Recovery, which is a CBT evidence-based program, and the aftercare program that Regen runs called Momentum, which is also a weekly CBT-based meeting that I still go to. I was in AOD counselling till February of this year, and then that treatment episode ended, and I was discharged from that service, which was right at the beginning of COVID lockdown, and then I used again. I had quite a low tolerance then, and for about a week I used what was quite a large amount, and that was scary for that little bit of time. I re-engaged with counselling. I went through an intake and assessment process again, and next week will be my final treatment episode with that counselling. Yeah, it's about returning and re-engaging. The other big thing I'm doing at the moment is the consumer participation work at Regen. I started doing that in September last year, and I've been doing more and more of that work since. Being consulted and engaged in looking at how Regen delivers services and talks about its services and engage with consumers is something that I'm finding really helpful and giving me some meaning. Yeah, and helping me to practice new skills, soft skills and hard skills, learning to write again and think again, and helping to improve my esteem and self-esteem and find new ways of being in the world. That's me done.
Thank you, Kit. Does anyone have any questions? We've got just a couple of minutes before we go back to Olivia. Okay, look, we don't have any questions at the moment, Kit.
That's right.
I'm sure people will think of things, and maybe, you know, as we're going towards the end, maybe we might have, a few people have actually come out and made some comments, and thank you for sharing your story, Kit. That was very powerful. Great job, Kit. I like your courage, and many thanks, Kit. And I would like to say the same thing to you, Kit. I mean, it's difficult enough to hop up in front of a whole lot of people and talk. It's even more difficult to hop up and talk about yourself and share what are, in fact, some really personal details. So, you know, yeah, I think that is very courageous, and I think you've done a wonderful job. Thanks, Kit.
Thanks, Jane.
Okay, Olivia, shall we try again?
I think that, yeah, there's one other question in the Q&A for Kit, and it says, beside the barrier you faced due to gendered classification, what other barriers did you face during your experience?
So I think the dual diagnosis thing is definitely a big barrier. It was for me, and I think it possibly is for others. Having to wait for treatment can be a barrier. You're not necessarily able to always wait, and therefore, yeah, that can be a barrier. Having housing, having stable housing is a barrier. Yeah, they're big ones, I think. You really need to have some sort of stable foundations before you can start making changes, I think. Somewhere safe to be and somewhere to, yeah, somewhere to come after treatment, before treatment. Yeah, that were the big barriers for me. Yeah.
Okay. Thanks, Kit.
That's right.
All right. And
back to you, Olivia.
Back to me. There was a few beautiful comments actually in the Q&A, Kit, for a bit that were really, I think, reflected what everybody said. But thank you for starting this off for me. I'm hoping that you can all hear me now. We had some trouble with the speaker issue. Thanks for the tip. Read the text stuff. I appreciate it. There's a stack to go through today. We've been given a very big list and there's much to go through, and normally I would probably do this amount of work over 3 to 5 hours. So we're going to probably motor through. I'm hoping that Jane will make the slides available to you. There's stacks of them.
Yes,
but they will be able, yep. So I've made sure that I've included the little lengthier slides so that you can go back and have a good look at that if that's useful to you. I'm going to share those slides with you now. There's, here we go. Screen 2. I'm hoping you can see that. Are you able to?
Yep, that's perfect.
Yeah, able to see that. Great. I wanted to thank you as well for coming along and participating, and also to Vada for inviting me along. This is, I think that this work is super important, and we all wear many, many hats. And if I can help educate people just a little bit, then it makes a big difference to all the work that we do as clinicians. So that's me. I'm working at Odyssey House. I'm Olivia Nichols. I work in the northwest catchment. Now, you probably know that all of the areas are broken up into catchments, and I'll talk about that a little bit in a tick, but Moses would probably have spoken about that last week. So this is a quick overview. We'll talk about a client's journey, just access to discharge. I know that Moses was did talk about this last time, about the service structure, but I'll just take you through quickly just as a reminder. We'll also talk a little about the brain on drugs, stages of change. That's super important in terms of treatment, and the complexity in minority kind of populations. And I think that Kit provided a brilliant introduction to particularly that bit. Jane, if it's cool, if I won't be monitoring the questions, but if you could monitor the questions, or James, and butt in when there's one of those, that would be awesome. All right, let's start. And I need to apologise now because I'm actually at home, and we have children at home, and we also have my partner at home who's I guess it's just the COVID reality at the moment. So this is from access to discharge, and Kit's spoken a lot about this already. The first step is to call intake. It's an intake over the phone. It's meant to be about 7 or 8 minutes, but our intake people are really clever at talking to people and creating trust, which takes a little bit longer. It's usually a bunch of demographic information and stuff, basic stuff around your substance use, and they ask a little bit around risk. You'll be locked in to attend an assessment. Usually that's face-to-face, but in this environment, it's either telehealth or over the phone. The assessment is lengthy, and I know that that's one of the barriers to treatment, but the gold that is taken from a good quality assessment really informs your treatment pathways and informs treatment later on. So it's super important. In fact, we talk about intake and assessment not being a paperwork job at all. This is about a therapeutic interaction. You may not talk to this person again, and and you need to capture that moment. If someone has a good experience of the first contact with an organisation, they will come back, and that is super important. So you'd attend an assessment. It goes for between an hour and an hour and a half. The assessors are very skilled usually at their work as well. They're clever, and they will provide a few interventions along the way. We do some treatment planning after that. The treatment planning, for us at least, we sit around in a meeting, and we discuss someone's story, and then we choose treatment around that. And of course they have input into what they would like, and then we were able to bring it back to them and say, look, I know you thought this, you might not be eligible for this, and this, and we really think this would work well, and this is why. And we'll do a little bit of that to and from, but it's important that we involve clients in their treatment planning, because that will dictate the success of it. The skill within an assessment as well is that you would provide a really thorough orientation to the AOD service sector so that people can make informed choices. There's lots of treatments available. Eligibility really does vary quite a lot. And the treatments, as most of you will know, there's counselling, and that's usually up to 15 sessions for what they call complex. Some people don't need so much. Some people need, for example, some relapse prevention and won't take so long. We do have care and recovery coordination, which Kit spoke about, and that's basically outreach case management. And they provide linkages as well, and slow engagement for those people that aren't quite ready or a little bit scared. Then sometimes that works well. We've also got day programs, so it's day rehab, usually go for about 6 weeks. We've also got residential rehabs, and they're many and varied. There are ones that are only 6 weeks long, and then there's others which are therapeutic communities that go for multiple years. We've got non-residential withdrawal, which is our nurses. That's home-based withdrawal, or considered to be a step up or step down into detox if someone needs a little bit more support. But for people to be eligible for non-residential withdrawal, they need to be quite stable, not have complex withdrawals to have at home, be trustworthy with Valium and all of those sorts of things. Unfortunately, COVID has meant that we can no longer do home visits, so our ability to provide a withdrawal at home has been decreased. And then, of course, there's detox. And detox generally goes 5 to 7 days, and you can detox from all of the substances you could possibly imagine, and that's a supported environment where you have staff. It's usually well staffed. They have group programs, those sorts of things, and they support your physical withdrawal. We know that withdrawal is really rough. That's probably it in terms of the treatments that are available. Of course, there are other services that are usually funded by, for example, the PHN, which may be population-based. For example, MyAF is the Muslim Youth and Families Program. Thorn Harbour Health has LGBTIQ specific counselling, those sorts of things. Discharge. So discharge is usually, oftentimes people aren't quite ready to finish the treatment that they've chosen, or together with their clinician they've chosen, and that's okay. So sometimes it's there's disengagement, or it's or mutually decide not quite ready yet. This discharge at this point is not a failure for any person. It's not a failure for the clinician, and it's not a failure for the client at all. We expect this to be part of the usual cycle. Discharge also means usually at the end of a funded period of time. Unfortunately, we don't get a whole lot of wiggle room around that. And for example, it's up to 15 sessions for counselling. It's 6 weeks for a day program. It's as long as a rehab program starts. There's a little bit more wiggle room for care and recovery coordination. That's funded every 15 hours, but you're able to work with somebody according to the guidelines for up to a year. Changes in treatment in the COVID environment. Wow, everything has gone remote. That means we don't get to see people's faces. We don't get to sit in the room with somebody. That's super important that we know that that's limited. However, we know now that before, in a historically face-to-face environment, that phone contact does work really well for some people. Means that also, it means that at the moment rehabs in country areas aren't taking people in Metro Melbourne. People have the services have decreased their bed limits, and day programs are now remote. So there's lots of changes. I've got down the bottom a revolving door, and people enter and they may finish treatment or they'll disengage, and that's fine. We call it, say that every interaction between now and then is a good practice, right? So that if you think about it that way, then we're not giving ourselves a disservice as clinicians, and we're certainly not judging our clients. Everything between now and then is a good practice. We're going to go to the next slides. Now, I'm not going to have time to go through all of these during this time. We do have the ADF drug facts. There's a drug wheel on there, and it's brilliant because you can click on all of the drug types, and it's actually a really useful wheel, and it goes through all of those, including the drug names and their effects, positive and negative. Now, I'm not able to have a lot of time to talk about this either because we've got to kind of whiz through. But basically, as you know, our drugs or substances, alcohol, interact with our pleasure receptors usually, and also our neurotransmitters. So we talk about dopamine, which is a pleasure response. Serotonin regulates emotion and improves mood. Gamma, butyric acid, GABA, we call it, and norepinephrine. So I'm not going to talk about those. We don't have time today. Maybe another time we'll be able to look at that a little bit more deeply. We also talk about the various areas of your brain where substances work, and that's the brainstem, limbic system, and cerebral cortex. I don't have time to go through those as well, but you'll get the slides and you'll be able to have a look. So we'll start talking about the more common substances. We don't have time to talk about the other ones, for example, but I'll be able to answer questions another time, or if we redo this another time, then we can do another session. Amphetamines, as you know, is a stimulant. Most of the time we call it ice, meth, speed, sexies, and as you know, stimulants allow increased energy, also in terms of increased dopamine within our synapses, which increases the pleasure response. Generally we see ice, we don't see much speed anymore. We see very little speed. Ice, actually, at the moment, I think the composition is pretty low quality and it's expensive at the moment, but we did have some of the best ice in the world in Australia for a period of time. And just so you know, the ice is often used in the context of sex as well, and this actually improves the quality of your sexual encounter. So it's important to know that that substances are often linked with other, I guess, actions, which, for example, gambling and those sorts of things, and it enhances your experience usually. We know that amphetamines can create agitation, decrease cortical cortex functioning, so emotional regulation, just like what Kit was talking about, impulse control, those sorts of things. We know that it also leads to, can lead to psychosis. And we know that when we burn out our dopamine receptors, that we find it difficult to experience pleasure, right? So that means we talk about a prolonged withdrawal, and people can actually remain quite depressed for a period of up to 18 months after ceasing. So just make sure that people know that. I'm going to talk about harm-in interventions because it doesn't matter where you're sitting in terms of your experience. Harm-in is a basic intervention. So we're talking about safe injecting, using clean equipment, no sharing, have a regular and trustworthy dealer. That's super important all the time, or use less if you've got a new one, and use in situations where there's less chance of a problematic behaviour. For example, you know, if you go with Johnny, then you're going to get a bit cross, then we make sure that we're not using with Johnny perhaps. We're going to talk about cannabis as well. We've got our own cannabinoid system, which means we're hardwired to like it quite a lot. It's good for sleep, pain, and creates a level of euphoria. There's 2 active ingredients in cannabis, and that's super important to know. One's called CBD and the other one's called THC. THC provides more of the heady kind of the big bang for your buck kind of experience, the real high. CBD is the one that mellows you out and makes you relaxed and giggly and all of those sorts of things. CBD is also the biggest ingredient in medical cannabis as well. In Australia, it's really difficult to get street high dose CBD cannabis. It's nearly impossible. And in fact, we've got some of the highest THC levels in our cannabis in all of the world, which makes it difficult because THC also makes you paranoid. and also makes you anxious, and all of those sorts of things that would harm, I guess, your mental health. We usually smoke it in bongs, of course, or joints, but it can be ingested. Hash is cannabis residue or oil, but it's not very widely available here. When we're talking about harming, we choose high CBD cannabis if possible. Non-hydroponic cannabis is best. It doesn't have the harmful additives and more likely to have high CBD. Make sure you clean your bong regularly and don't share, particularly during COVID. That would probably be a very bad idea. Synthetic cannabis, I'm not going to talk much about it, but just to know that it's incredibly potent. It's made out of chemicals. It is not good for people. We see a lot of people needing hospitalisation after using and when they're in withdrawal. So we usually, the harming intervention here is usual clean bongs, don't share, but swap to naturally grown cannabis if at all possible would be the best harming education that you might provide. Now we're talking about opioids. Opioids include heroin, cocaine, pethidine, fentanyl, methadone, Suboxone, all of those sorts of things. Opioids can be both prescribed and illicit, as you know. It can be ingested, injected, or shelved. Shelved is when you place it into your bottom. And it's actually a really good way to absorb opioids, particularly if you think oxys. Oxys actually have a 90-something% uptake in if shelved, and a 60 or 70% uptake if you inject. So if you can recommend someone using oxys to shelve rather than to inject, then they'll get less of a rush, but a bigger effect from their use. Decrease pain and anxiety and create a euphoric effect. Now we talk about the bubble phenomenon. A lot of people who experience trauma require a bubble because it's hard, you know. When you're confronted with trauma every day, then a bubble is really helpful. Methadone also provides the bubble. Suboxone, not so much, but that's why both are available. We need to know that we need to be able to deal with trauma and distressing thoughts and those sorts of things before we take away a bubble. So it's really important that you know that they're CNS, central nervous system depressants, which means that they affect your heart rate and your breathing, and that may lead to respiratory depression and death. First aid, CPR, and Narcan or naloxone is readily available, so please encourage people to access those. Tolerance. I'll talk about tolerance in some of these, and tolerance increases quickly and decreases really rapidly. So even after a short break, you'll find that your tolerance with using has decreased so much that an overdose is likely, and we need to be careful. We talk about halving your hit. It's better to have 2 holes in your arm and be alive than 1 hole in your arm and be dead. We talk about withdrawal as well. Straight withdrawals are no longer recommended, and most detoxes will not do a straight withdrawal. They will want you to go onto Suboxone or methadone and create a period of stability for multiple months before slowly weaning off. The reason why they were doing that in particular, or why that's changed, is they were finding that a lot of people after a straight withdrawal were actually dying because they weren't ready to stop, and when they were using, they were overdosing because their tolerance had dropped so quickly after being detoxed. Of course, harm-in means safe using in terms of not sharing, clean equipment. If you're using pills, use a pill filter, and make sure you have naloxone at hand and use with other people there. And if your mum's going to be in the same house or something like that, we train up, give the mum some naloxone so she can administer, or partner. Alcohol. Okay, this is one of the most common substances that we see. It affects many of our neurotransmitters, and of course in the brain affects communication, coordination, relaxation, and increased pleasure. We also know it's again a CNS depressant, and it is also one of the leading causes of morbidity and death as well, in terms of long-term use linked to cancers and many other things. It's also really well linked. It's linked to ABI or brain injury as well. So we actually lose brain matter when we drink. Tolerance. So soon the body actually needs alcohol to simply function. And we need more and more to create the desired effects of intoxication. It's important to know that. With withdrawal, you need to be careful. Alcohol withdrawal should be medically assisted. For those who use high levels and over a long time, unassisted withdrawal or going cold turkey can cause seizures, coma, and death. The harm in here is do not stop drinking suddenly. We do have people arrive at our assessment with bags packed, or with people who want to finish now, or with partners who say, well, you've got to finish, you've got to stop drinking now, otherwise we're over. We need to make sure that we do not stop suddenly. And we need to remember not to mix CNS depressants, because that would increase your chance of overdose and death. We can suggest swapping to lower alcohol drinks, for example, wine to beer. Benzos, and these are both prescription and illicit. They come in tablet form. We know that there's a lot of benzos out there on the market, probably a result of safe script, and they look very similar. So at the moment there's some from America which are kind of a little more trendy, but there's also ones on the market at the moment that are pressed into Xanax type bricks or tablets. They look exactly the same. They're made of something completely different. People are having overdoses. We need to be super careful about where we get our illicit or prescribed pills from. You need to know that they're CNS depressants again, of course you know that. And they affect emotional reactions, memory, thinking, all of those sorts of things, decreasing your heart rate and your breathing, fabulous for anxiety. And also, of course, euphoria, because we wouldn't use substances if it wasn't either treating the pain that we're experiencing or providing us a pleasurable, I guess, experience. Tolerance, soon the body needs benzos simply to function. And then we require more and more to create the desired effects. Withdrawal, don't stop. Don't stop using benzo suddenly. It should be medically assisted with a tapering off of benzos. If you've been using a lot of benzos over a long period of time, you need to do a slow reduction over many, many months, because your body is used to the benzos, and it will, and you'll find it very difficult. Remember, if you're using IV, you need to use a pill wheel filter here. Do not mix CNS depressants. You're in a bad way if you use opioids. Take a couple of Panadine Forte, have a few drinks, and then have your benzos on top. It's disaster. There's other drugs. I'm not going to talk much of anything. Well, I'm not going to talk about these drugs, unfortunately. We don't have time. There's MDMA, GHB, GBL, LSD, mushrooms, ecstasy, ketamine, and cocaine. We're seeing a lot of cocaine at the moment. There's a lot of people that come through using a lot of cocaine, and of course the associated side effects of that, and a lot of people using a lot of GHB as well. We had a GHB drought for a long period of time, and now we're getting people, normally you have it in 2 to 3 mil charges, and we're getting people in who are using 160 mils a day. Usually that goes hand in hand with ice use as well. High levels of ice and high levels of GHB are often associated. GHB is super, withdrawal is really hard, and it needs to be medically assisted. It is, people can die from withdrawing from GHB. You need to get help. I'm going to talk about stages of change. Now I'm going to need somebody from VADA, if that's okay, to give me time prompts. 2:51, how much longer do we have? 3:15. With some questions at the end, so maybe we've got 15 minutes. Would that be right? 15 minutes? All right. Now, I know that this is a little slide, and I'm sorry, but this is about stages of change. it's super important to know about stages of change, and you're going to know, and of course I'm pretty sure that most of you will, but of course there's pre-contemplation, which is like, what problem? I don't have a problem, this is great. There's contemplation, sorry, and that's maybe this isn't going so well for me, I'm noticing some not good stuff. Then there's a decision made, and that turns you into action. Something's not going right here, I need to do something about it. And then there's maintenance, and this is, I'm still not using, but maybe I need a bit of help to continue not to use. And then of course there's relapse. Now relapse and lapse is not a failure, it's just we just talk about having a practice run. A lot of our treatments are based on the stages of change, so that would often dictate the way that we would work. Organisations, most organisations are not abstinence based. We talk about functional and dysfunctional drug use, but unfortunately what usually works for people is complete abstinence. So we work with where people are at. So with pre-contemplation, what would you do? You provide harm-in interventions. We don't want to stop, but let's make sure that you use safely, yeah? We will educate about substances, the way that they would work, and create insight into perhaps the negative effects. So it might be that someone hasn't really linked their relationship issues to their substance use. So you might have a look at that with a client. And you'd also provide some information about how to access support when ready. For contemplation, so I think something might be not great, we'd continue to provide harm-in because usually someone's using at that time still. And we work to increase insight into the negative effects of substance use. We provide information about the substances, their effects, and drill down a lot further sometimes, depending on where a person's at and what they're ready to hear. We provide motivational interviewing and some elements of CBT. And we provide orientation and education about the AOD sector and what to expect. Action, I'm ready. And that's where some of the real work begins. I guess someone's ready and let's run with that. We talk about, there's a lot of therapeutic options, and what you will find is therapy is, usually we have social workers and counsellors providing therapeutic interventions. And that would include mindfulness, CBT, ongoing motivational interviewing, acceptance and commitment therapy, and stacks of other therapeutic interventions. Probably psychoanalytical work isn't going to be long term. We don't have enough time to do that work. It depends on what you've got in your pocket in terms of clinician, what you're good at, and also what the client is ready for. And then we provide more orientation to the AOD service system and what things would look like if you were to be discharged. All right. Now, here we go, maintenance. I'm sorry, I missed that one. Maintenance is, I'm happy where I am, treatment is complete. Here the interventions would mainly be relapse prevention strategies. And that would be continuing to use mindfulness, how to manage cravings, avoiding triggers for use, improving emotional regulation. And as Kit said, that when he got towards the end of his treatment, he was a little more ready to look at PTSD and other things that were going on for him, address some of the mental health issues. And we see that that is true.
Hey, Olivia.
Sorry, I'm sorry, Kit. I apologise for that. Kit, you would have heard how Kit was now ready to address that. Would you like to talk a little bit more to that point, Kit?
So I suppose it's just that once I had more stability in my head and once I was able to regulate my emotions myself to some extent, and now I am to an extent, that's when I can start looking at the trauma and start to sort of think about it. I've got some capacity and some distance, if that makes sense. You have to be pretty mentally present to be able to start dealing with the kind of trauma stuff or dealing with looking at your thinking or looking at how you feel. Yeah, so that's sort of quite recent that I would be able to start looking at that stuff and not end up in a bad place mentally because I didn't have any of that control or perspective, I suppose.
Yeah, that's exactly my experience, and I'm pleased that it was your experience too, because in the end it's your voice and every other consumer's voice that matters in this space. And if we can make things fit and make things work for our consumers, then we know we're doing a good job. So most AOD counsellors do not have specialist qualifications. And that's okay, because we don't need them, and there's lots of places we can refer to. So once somebody is showing some readiness, we can refer to places like CASA. Now, many of the women that we see and men have had significant sexual trauma as children or as adults. And oftentimes when you are clean and dry or using less, then trauma resurfaces and flashbacks and things like that happen. We as AOD clinicians can talk about how to regulate emotions and use mindfulness and those sorts of things. But in terms of exploring that trauma, it's probably a trauma specialist that you would send to. We do trauma-informed care, that's super important, but often we don't have the specialisation. Grief and loss counselling, most people who use substances have experienced a loss over time. And we continue to be affected in many ways. Go on to the next one. Now, almost all clients presenting to AOD services have multiple and co-occurring complexities: mental health issues, homelessness, financial insecurity, family violence, involvement in the criminal justice system, and perhaps gambling issues. So when someone comes to the service and they present, when they're not presenting necessarily as like alcohol is my only issue and that's all I want to deal with. This is a person who is multifaceted and there's many, many things going on. As Kit said, most people who attend AOD services have significant mental health issues. Most of them are under-serviced for their mental health issues and not well connected. There's a lot of people who attend who are homeless, whether that be street-based homeless or tertiary homelessness, couch surfing, maybe living in crisis at home, etc. And then there's those that are looking in rent arrears and not able to pay their mortgages anymore, and they're on the precipice of homelessness as well. It's really hard space to work with because there's not a lot of housing options out there for people who are experiencing homelessness. Financial insecurity, of course, usually substances cost a lot of money and your ability to work is decreased. A lot of people, many people that we work with also deal in order to be able to pay for their own substance use. Family violence. Look, most people that come through, unfortunately, are currently experiencing or have experienced family violence. And we're not just talking about physical family violence, we are talking about all of the other types of family violence. We work with perpetrators and we work with affected people, which would be affected family members, usually AFMs they're called. And now that MARAM has come along, we have got a whole different lens that we need to use when we're dealing with people with family violence. We need to always have a family violence lens. I would recommend you to become quite au fait with understanding how to assess for and manage family violence. We know that with family violence, coercive control, stalking, those sorts of things can be just as much a risk as someone who's getting a punch in the nose. We know with substance use, mental health issues, all of those sorts of things contribute to increased family violence risk. It's super important. We need to have that lens. Involvement in the criminal justice system. Many people have got previous charges. And that's fine because we work with people. Some people are directed by courts to attend treatment, and sometimes that engagement looks a little bit different because people aren't necessarily ready for change. And of course, there's gambling issues, particularly associated with ice, actually. We see a lot more people gamble with ice. Gambling has decreased significantly because people can't go into pokie venues recently. So with all of those things, we need to have those lenses. So mental health, homelessness, financial, family violence, and understand criminalised behaviours. But they're not our core work. So I think that what you'll find is AOD service provision is probably one of the most holistic service provision areas. We don't just deal with people's housing, homelessness and those sorts of things. We support people to access further services if possible around all of those issues. People that attend AOD services are not considered straightforward or simple necessarily. We have a story, and there's a reason why we are where we are, and our story is oftentimes difficult and painful. I'm going to talk a little bit about specific and minority populations. As you've heard from Kit, Kit has told us a little bit about his experience as a gender diverse person. Kit, you were really good at showing us the barriers for people who identify as LGBTIQ. And all of the other letters that continue after that. Unfortunately, not many services are built for people who are different to the norm. There's no norm, I don't think. But for minority groups, youth, Aboriginal people, people with disability, ABI, unfortunately, this is a flawed system. And that means that your specific treatment needs may not be met by the service structure. Oftentimes we talk about perhaps, for example, for people that need interpreters or have ABIs, then probably case management and counselling are your options, because attending groups and those sorts of things can be difficult, and oftentimes it's an eligibility criteria that you need to have a level of English, be able to speak English, but also understand the basic, I guess, in terms of ABI. If you have low cognition, it will be very difficult for you to attend group-based sessions. It's also difficult to attend counselling. We know that there are places that provide specialist services, and that would be places like Horn Harbour Health, which is LGBTIQ specific. There are youth services, of course, and you would access, there's a website called Yoda that's run by YSAS where you can have a look at what's available. There's Aboriginal people who access services. Now we know that people with diverse backgrounds are overrepresented in the substance use users population, and we know that they're underrepresented within services. Our office is in Footscray. We have a large African nations population there, and we see with multiple and complex needs, and we see very few of them. Our demographic is generally white, Caucasian, usually male, people who understand how to access Google and all of those sorts of things and can navigate those systems. We know that it's flawed, but we do our very best given the constructs that we've got. In terms of access, that's me, that's who you would talk to in my region. And my job is to make things easier for people that have trouble accessing services to access services. We need to understand, have cultural understanding, of course, attend those the sessions and ask people. People are experts in their own world. Be curious and ask and double check. I think you get permission to do that when you're respectful, and it's important. You use that person to be the master of their own journey, and that's super important. I know, Kit, that it's not been ideal being slotted into male only environments. Unfortunately, we've not caught up very well with where that needs to be, and even genderless toilets and those sorts of things at services are non-existent. We have also access to services, for example, MYAF, Muslim Youth and Families, which is for Muslim people, so adults, families and young people as well, and that's out of Glenroy. It provides a really good lens and understands the cultural aspects. There's also the VMA down the bottom is Vietnamese Women's Association, for example, in Footscray. And that's where you can access, it's not for Vietnamese women, it is Vietnamese specific AOD treatment. So you can access a AOD counsellor there in your own language if Vietnamese is your language, first language or your language of choice. So it's flawed, but we try our very, very best at making things work in this world. And I think that there's actually incredible investment in making things work for other people. We've just got to have people in those services that are happy to move forward in that way, and of course the funding to back it. Would you like to ask any questions? I might actually, no. Would you like to ask any questions, and we can talk about eligibility or specific drugs or anything like that, or about the service system a little more? We can do that as well.
Olivia, there's a couple of questions here on Q&A that we can have a look at. The first one is, I know there's probably no simple answer to this, but roughly how much would someone need to be drinking before medically supervised withdrawal for alcohol was necessary?
Sure. For my non-resi nurses at home with Valium, under 20 standard drinks. Look, if you're drinking a bottle a day and you're finding that you're waking, we often use the withdrawal scale. So we're talking about blood pressure, heart rate, and tremors particularly. And you would be basing that on previous experiences of trying to withdraw. So whether there's tremors, whether you're finding nausea, vomiting, those sorts of things. If you can be drinking half a bottle a day and be experiencing significant withdrawal symptoms. So it's very, very, I guess, subjective. We'd also look at whether someone's got health complexities. A history of seizures means that if you've had a history of seizures ever from either epilepsy or stopping drinking or stopping using benzos, then you need to have an inpatient withdrawal. We know that people who are drinking a lot of alcohol, for example, we do have people come through drinking 4 to 6 litres of wine per day. We know that needs to be medically assisted. You will find that even though people are drinking 4 litres of wine, they may not appear intoxicated. They may blow a BAC of 0.3 and they'll still be able to reverse their car. You watch out the window and you'll be able to reverse the car into a car space better than I can. So that's what we talk about tolerance as well. So it's subjective, but I would say under 20 drinks with no physical complexities, and Valium is a good option, and you can access that from your GP. You don't need to have a home-based withdrawal nurse to access that. Your GP will keep a very close eye on you. You can also look at reductions for people that drink a lot more. We can look at a slow reduction over multiple weeks, and that's usually a safer way to go about it, especially in the COVID environment. Family systems used as a counselling intervention. Now, that's super important to know, because we know that much of the time our experience is that just like what Kit said, oftentimes your using is significantly linked to your current partner or your ex-partner, and oftentimes an increase in use is linked to being partnered with people who use a bit more. We do a number of interventions. There is family counselling available. A lot of organisations have family AOD counselling. For example, CoHealth has Tess Darlington, and she provides family AOD counselling for the partner. There's also, we provide single session family work as well, where usually that's around understanding intoxication and drugs, the issues that you might find with your partner, the orientation to the service system, understanding harming interventions like not stopping alcohol immediately, and also support to access further services. We also use single sessions in our organisation to screen a bit more heavily for family violence. So we'll have a perpetrator come in and we're worried about the safety of their partner, but we have not a lot of proof, because we know that people, I guess, they downplay their part in that space. So we may get someone in for a single session and do all of that work, but also inquire respectfully around what their experiences of family violence might be at home, so that we can manage that risk. There's also Shark, and they provide group work for families. So there's a family support groups, and also education groups. For example, they've got In Focus, and they've also got Breakthrough. In Focus is a family support group, and Breakthrough is an ICE education program for families. It's actually quite good. I'm hoping that would be answering your question.
I think so. And the next one is, for someone who is experiencing homelessness, is it generally preferred by services that some form of housing is secured prior to entry to detox?
Unfortunately so, because people want to demonstrate that they've got some sort of stability in order to be able to stay, I guess, substance-free afterwards. If you're returning to your same homeless life afterwards, then it's going to be more difficult for you to remain stable prior to that. Sometimes we can negotiate someone to enter detox and therefore gain housing, so go from detox into housing if it's pre-arranged, but usually it's one of the barriers, and I think, Kit, you were talking to that before.
Yeah, I also did. I entered detox at one stage when I was on the street and left it back onto the street. That was not a good intervention.
Yeah. So it's difficult. If you're returning, I'd say that absolutely securing housing of some sort prior to detox is important.
Okay, we've got one last question. At Odyssey House, what roughly is the wait time for residential rehab?
Yeah, I can probably give you an idea of most organisations, because my job is to help people choose treatment pathways, so it's kind of my job to know this stuff, although I have been on holidays for the last 2 weeks and you never do know what's happened. Then at Odyssey House, what I'd last heard, it's 3 to 5 months to get in. Methadone beds will take longer because they've got a cap on that, because it's difficult to take people into town to get dosed and then back. And family beds, actually, last I heard, had a shorter wait time. Now, in Odyssey, it's one of the only places you can go with your family, and you can also go in as a couple, and we also a bit better at supporting LGBTIQ, people that identify as LGBTIQ. The other ones, for example, Westside Lodge has got up to a year at the moment. Most places who are based in the country, so we've got Bairnsdale and Circuit Breaker as well, they're not taking people from lockdown areas. So most country rehabs are not taking people from lockdown regions at all, which means that our options are very limited, unfortunately, and the wait times are very long.
Okay.
In terms of, in our region, accessing an assessment at the moment will only take a couple of days up to 2 weeks, but usually just a couple of days. Accessing counselling, a couple of weeks. In our region, accessing day program, it's when it's scheduled, and accessing CRC and will take a couple of weeks. Kit spoke to accessing treatment quickly being important, so we do try to start at least the process very quickly. We know that waits for rehabs are exorbitant, and we know that waits for detox can also be a very long time, and when someone's ready, they're ready, and we want to jump onto it.
Yeah. Okay. That's brilliant. Thank you, Olivia. Now I know why you said you could spend 3 to 5 hours talking about this, because it's really complex, and I guess it's some of the challenges that people who work in the AOD sector face. So thank you again, especially coming on leave, and I don't have any doubts that we'll get you back at some point to do some more of this, because it was really good. Okay, so thank you both, and I will hand you now back to James just to finish up.
Thanks, Jane. And yeah, thanks, Kit and Olivia. Both of your talks were fantastic and really sort of complemented well the first part that we had last week. So thank you very much for your time and the care you took in preparing your presentations to us. I'm sure everyone's found it really, really valuable. And thanks everyone for attending. Thanks for all the questions. A recording will be made available, so will be a link to the recording will be available, and Olivia's slides will also be available. So thanks everyone, and again, sign up to either VADA's, VHA's, or the Centre's news lists to stay up to date, and please fill out the poll if you have time. That'd be really wonderful. All right, thanks everyone.
Thank you. Thanks for having me. It's good to talk to you all.
All right, thank you.